right track. Absolutely. Did you hear what she said? Say it louder.
Baby delivers, the delivered foot first, and the head is the biggest part, so that's the hardest to come out. And then the head might be stuck in there.
Yeah, and the cervix only has to be maybe 5 or 6 centimeters to let the body slip through, and then the body, so that now you get down to the neck, and the cervix starts to close down. It says, okay, I'm done. Starts to clamp down, and the head is still trapped inside. And we have Professor Walker back with grades. Yay, Professor Walker. Oh, she's not
You
happy.
people!
I'm so sad. Can you put the Elmo up for me? It's just one question that we did throw out. We threw out one question. But it's okay, because we basically did that question in class. So I really think it's important to take a few minutes to see how people were thinking.
Slide it. Oh, you're.
I don't want to. That's the one she wants. Which assessment indicates a need to order a magnesium sulfate blood level? Select all that apply. Magnesium. Given for why? What are we going to look for if we have too much or too little? Reflexes and breathing, right? Breathing. It's going to relax us so they're not going to breathe. They're going to have no reflexes, right? Yes.
It's still normal. That's why they choose.
That's a good answer because it's a trend. Still normal, but a trend. Remember? That's a good one because we don't have as much mag, right? We're still hyper. Blood pressure. Does mag have anything to do with the blood pressure? No. Really? Okay, so nobody should have really picked that one. And this one. Does mag have anything to do with the liver and the pain? But you all said it. Enough of you got it wrong that we had to throw it out. But think of what we said. If there's not enough of you, the next level is selling us. That's my big mistake.
I didn't realize it.
Right, so it could be, she's still real brisk, so we haven't had enough mag in there yet, so we'll have a low mag level more than likely.
Oh.
Or, right, okay. And the question is, when do we draw mag level? As we work with this patient, we're assessing the patient, what things would make us think, hey, I don't think she's got a therapeutic dose on board. She may have too much too little. I need a mag level now. Here.
So the only thing about A that, like, for me was a problem is that we didn't give a time frame in the study, right? And so in class we discussed it. We said that would be something you watch because it's a trend. And I think the example on top of like 60 to 30. We'd watch it, but for me that meant that would be something I keep an eye on without a time frame, not necessarily be the thing that prompts you to order a mag level. You know what I mean? Since 30 is still normal,
It's still normal, but we're not worried with mag. Are we really worried about hydration? As much as what we're worried about is she's not peeing as much out as she was. So we had her on a mag level here, and she was peeing 70 an hour. But now she's only peeing 30 an hour. So all the mag we've been pouring into her is probably too much, right? And she's probably holding it in there. So that's why if a nurse sees that here and out drop that dramatically, it's time to check it again to make sure we're not overdosing her with the level we gave her at 70 cc's an hour. A lot of you want that answer too.
Those are the opposite of opposite findings. One would be toxicity and one would be.
Exactly, right, exactly right. And when you're dealing with the mag level for 4 to 7 that we want, you've got to be concerned if it's at either end or off that scale for the very reason. You don't have enough, you're not helping her. She's still possibly going to seize on you, and then we know what it is if you give her too much. So I think going into the next quiz and going into the final, really think these through. And like I just did with you, cover up your answers if you're not doing it already, and think about the question. So this is asking, what about mag? Go through your brain, think of all the things you know about mag. Too much, too little, mag, run it through, and then you might be a little bit more prepared for some of these. It's always surprised. But we did throw it out because so many people got it wrong. So we did throw it out. Thank you for your time.
No problem.
That would be a bomb.
Well, I mean, not really, yeah. Okay, throw it out. I don't think
No, not really. She's had to go.
I saw that answer.
She did like this in your November.
We talked about the breech position, and those babies, first time babies are delivered by cesarean. There is a procedure that can be done with babies that are in the breech position that sometimes is effective in turning them from butt down to head down. And that is called version. Have any of you had an opportunity to see a version while you were in clinical? You got to see one?
My patient just had one,
Okay.
and I didn't actually see it. But it's, they turned the entire baby around from, I think they were in transverse lie, and doctor, second attempt, is cephalic head version? No, cephalic,
Turn the baby to cephalic presentation.
yeah, odd version. And, just by maneuvering.
Did you see one?
Not in clinic, but I was a birthing coach to a friend of mine, and
Uh-huh.
she had that.
Okay. What they do, there are a few things that can be done to help a baby turn. Sometimes some obstetrician midwives will have patients start as early as 28 weeks if the baby's in a breech position, doing some exercises that may facilitate the baby flipping. Some patients try acupuncture or active pressure as a means of trying to turn the baby. And if that, and there's also some herbs that can be used by people that are skilled in that. And when that doesn't work, or if it doesn't work, there is a medical procedure called version, where basically the patient is being monitored with ultrasound so that they can see that the placenta is not being pulled away from the wall of the uterus as they do this maneuver, and watch the cord. And it takes 2 people, so I'm going to pretend, actually we'll use our little model right here. Use her later. These are her legs coming down here. And this is her belly. So there would be a healthcare provider on this side, and there would be a healthcare provider on this side, and they would be strong people with big hands. Some places use a little bit of an epidural before they try to do this. Some places use a little bit of a drug that we'll talk about with preterm labor called a tocolytic to relax the uterus. Some places don't use either one. But they approach the baby, they have palpated where the baby's laying, and they're basically trying to get a hold of the head, which is up here, and the butt, which is down here, and by pressure on the small parts and the back, pushing this way, try to spin the baby. And if it baby isn't spinning this way, then they'll try to do it the reverse way. They are very careful with the head, but they're trying to make the baby spin around. And they don't usually try to do this before 38 weeks. Why would that be? What's the risk with doing this? You're manipulating the back of the uterus. What's the risk? Rupture of membrane, right. So you want the baby to have mature enough lungs that it's going to be okay if it delivers. And you are turning the baby, and many places, well, once they have turned the baby and gotten it, if it works good, it's head down, they'll go ahead and they'll induce labor then. Because the disadvantage is that if the water doesn't break and all is good, that the baby flips back the way it fit before. It likes that position, and it's going to go right back to where it was butt first. Okay? So that's version. As a patient going through this, it is not comfortable. It hurts big time because there's hands that are reaching down and digging into the abdomen in an attempt to turn the babies. But for people who are motivated, who want to be able to deliver vaginally, it's an excellent thing and it works. Not for everybody, but it works for a lot of people. Okay. Malpresentations would be with the face coming first or the forehead coming first, ways the baby doesn't fit through very well. We talked about multiple gestations just in the context of it making a more high-risk pregnancy. But twins aren't always head down, are they? Sometimes they're side by side in each other's arms. Very sweet, doesn't deliver well that way. Sometimes one's head down and one's butt down. So they don't usually try to manipulate twins with aversion if they're not both fertile. Macrosomia, that's a problem with the passenger, big baby, and it may not be able to deliver vaginally. However, if it's decided that it's macrosomic from an ultrasound in the last couple weeks of pregnancy, is that very reliable? No. Not really, because what does the ultrasound measure? It's measuring bone. Yeah, it can't talk about the padding. So, notoriously, people have oftentimes had cesarean birth for a baby that's judged at being macrosomic, when it's more the way the mother's carrying the baby, and it may be big bone, but overall the baby may not be all that big. Hard to judge externally. And then there is shoulder dystocia. And I need a volunteer who believes themselves to be nice and strong, because I will be the first to say I'm not. Please. We're going to deliver this baby with shoulder dystocia. So somebody help me.
Let the man do it.
Are we sexist in here?
I was nominating him.
You were nominating him. Anyhow, I don't really care, I just need a person. Por favor.
Yeah, cat.
Woo, get back. There you go, guys.
Thank you.
Just turn it.
We're not going to break this patient. You need to move around and see, feel free, because we're actually going to deliver a baby with shoulder dystocia. I am going to hands first. Sure. Have any of you seen a baby delivered with shoulder dystocia in clinical? Well, typically, in most delivery rooms, when they're getting ready to deliver a baby, there are two people present. When they anticipate a shoulder dystocia, they get a lot more people in the room because it takes a lot of hands to do this. One of the red flags for shoulder dystocia would be a baby that's LGA or macrosomic, because they're more likely to have broad shoulders. In shoulder dystocia, the issue is that the head is not the biggest part of the baby. The shoulders are the bigger dimension. So we're gonna be able to deliver this baby's head,